respected senior members, colleagues, and many friends amongst the audience. We are meeting after several years. Neha, very good morning to each one of you. At the outset, I would like to put on record my sincere thanks to Professor Jiangming Li and other members of the scientific committee to have given me this opportunity. I bring you greetings from Apollo Hospitals, New Delhi, in India, where I am working these days. I will be talking about journey of PCNL, its past, present, and future. I have no conflict of interest. Occurrence of stones in urinary system is a very old disease. Even 5,000 years old Egyptian mummies have shown stones in their kidneys. A wide portion of the world stone belt crosses over India and China, which are the most populous countries of the world, and therefore most of the urologists of these countries are engaged in managing urinary stones. There was no confusion till 1975 when all of us used to do only open pyelolithotomy or nephrolithotomy, open stone surgery. That was the only modality available. Percutaneous removal of stones started in 1976. In fact, the first nephroscopy, means seeing inside the kidney with the telescope, was done by Ruppel and Brown. While doing a open pyelolithotomy, they passed a cystoscope inside the kidney in 1941. But in 1955, an interventional radiologist, Willard Goodwin, was trying to perform a renal angiography and he accidentally punctured a hydronephrotic kidney and drained some pus and urine. He got scared. As it happens, if there is some mishap, you leave a drain over there. So he left a nephrostomy tube inside. And this became the first percutaneous nephrostomy. After that, this procedure was used many times for draining the pyonephrotic kidneys as well as for chemical dissolution of the stone. They will do two nephrostomies, and from one the chemical will go in and from the other side it will be drained out, and the chemical dissolution will continue for about 3 weeks to 3 months. Patient will remain admitted and they thought that the stone can be dissolved. So this way, the percutaneous nephrostomy was being done, but nobody ever thought of picking up the stones from the same track till 21 years, when in 1976, Famstone and Johnson first picked up the stone with the help of cystoscope from the nephrostomy track, and then they published this in Scandinavian Journal of Urology and Nephrology as first three cases of percutaneous pyelolithotomy. This publication generated enormous interest in percutaneous approach to the kidney. Arthur Smith in USA, when he was trying to do a retrograde stenting for a obstructed ureter, and he was unsuccessful because the patient had undergone a Cohen's ureteric reimplantation. So he punctured the kidney from above and passed a antegrade stent, and he was successful. He was so excited, he called this technique as endourology, and he mentioned that it is a good application of percutaneous approach. But his residents, because the instruments were not so well developed, everybody was struggling in the OT with this percutaneous punctures and surgery through the kidney. So the residents started calling it as end of urology. But anyway, endourology continued to develop. Then Kurt Emplarts, who was the interventional radiologist in the same department, Dr. Arthur Smith and Kurt Emplarts, they started interacting with each other and started developing instruments. And later on, these five gentlemen, Dr. Peter Elkin from Germany, Joe Segura, Arthur Smith, and Kurt Emplarts from USA, and John Wickham from London, UK, Then they started meeting, interacting with each other in various conferences in EAU, AUA, started exchanging and started developing instruments for percutaneous approach to the kidney and for removal of stones. But at that same time, there was no effective fragmentation device available to break the stone inside the kidney. So they had to pick up the whole stone intact from within the kidney, and for that, they needed to increase the size of the hole in the kidney, or the nephrostomy tract has to be wider. So they started dilating the track either with metal, plastic, or polyurethane dilators every day till the stone size was achieved, and then they started removing the stone intact. And when you have to remove a intact stone, a large stone, you need a good sturdy forceps of 10 to 12 French. So they've developed a large nephroscope of 24 to 27 French. Through the working channel of that, 10 to 12 French forceps was passed, and the stones were picked up from there. And this was called standard PCNL because they were using 24 to 27 French nephroscopes, and obviously the implant sheath which we used for the nephroscopy, for the nephrostomy, used to be 26 to 32 French. So this continued for next 15 years. But when they published their data, Dr. Ralph Clayman, Arthur Smith, and Kurt Amplards, when they published their first 63 cases of percutaneous removal of stone in American Journal of Radiology, because most of the tracks and dilatations were done by the radiologist, by interventional radiologist, the PCN track size was up to 50 French. This was the average size. So don't get alarmed, this is possible. The first World Congress on Percutaneous Renal Surgery was held in 1983 in London, in 84 in Germany, and in 85 in New York. And this is the first scientific this kit which was given during the first World Congress of Percutaneous Renal Surgery in London in 1983. In India, PCNL was brought by Arthur Smith in 1983 by demonstrating in an operative workshop at Jaipur, and then another workshop was organized in Mumbai, and then in Indore in 1985. I attended these two workshops, one in Jaipur and one in Indore, and I was so mesmerized with this technique that I chose it as my career for my lifetime. But in fact, PCNL was introduced in India by these five gentlemen, Dr. Percy Chibber and Deepak Kirpekar. They went to John Wickham and then to Arthur Smith and learned PCNL. Our Shivdev Bapat, he went to Peter Elkan in Germany and learned PCNL and came in India and started it. And when Arthur Smith came for the first workshop in India, these two young boys, D.N. Kalla and K.K. Sharma, they helped him in doing the PCNL and learned from him in the workshop. And these five gentlemen, they started doing PCNL and spreading the knowledge of PCNL in India. So this was the happy beginning of PCNL in India. These were my teachers of PCNL. I learned 7 cases from Dr. Bapat and saw one case being done by Dr. K.K. Sharma. Then I picked up this technique and I started way back in 1987 at Manipal. Soon after, Dr. Mahesh Desai in Nadiad, Dr. Janak Desai in Ahmedabad, and Madhusudan in Agra, we 9 people started doing PCNL and started teaching PCNL in Indian subcontinent. But all of us regard Dr. Shivdev Bapat as father of PCNL in India. I started visiting China way back in 2005. I made many good friends. I made 24 visits to China. I went to the house of Dr. Zheng Gohava and I made good friends with Professor Li in Jiangming Li in Kunming, many friends. And then I came to realize that this PCNL technique was brought to China by Professor Kai-Jun Wu in 1984, and that it was later picked up by Professor Li Zun and Professor Zheng Guohua. But all of them started doing PCNL with the help of 9.8 ureteroscope from Wolf. This is the way they were doing PCNL, and I saw In 2005, Professor Zheng Guoava helping Dr. Sanjay Khadgi, and they were doing PCNL, and this was my first time when I saw a Chinese PCNL being done. These were the peel away sheets. For the first time, I saw how these were being used and how they were using the rotary pump, and with the help of a ureteroscope, they were able to do PCNL even for staghorns. So all over the world, PCNL continued to progress for next 10 years from 85 to 95. Earlier CMs were not available, but these started becoming available in different operation theaters all over the world. But 24 to 27 French nephroscopes were the only nephroscopes available all over the world. We used to use Elkin metallic telescopic dilators and used to make the track of 30 French. Karl Storr's ultrasonic lithotripters were available for breaking the stones, and standard PCNL became the norm, most glamorous technique in urology world. And even for small children less than 1 year of age, we used to make a track of 30 French using 24 French nephroscope, and we were able to remove the stones. But at the same time, during these 15 years, PCN was challenged with the ESWL. Christian Chaucer developed lithotripsy, and we started thinking that this is the only technique which will be most successful. But this was unfortunately overused for each and every stone, and gradually the use of ESWL came down. But PCNL continued to develop all over the globe. It won over the fierce battle against ESWL and emerged a clear winner in terms of providing maximum clearance of stones from upper tracks. But at the same time, some people, some operators, they were not able to give good results, and they started noticing catastrophic complications, mostly the bleeding complications, and they started getting discouraged by use of PCN. In 95, an idea was mooted. Why don't we make a smaller track? And then they started using a 15 French track, a 10 French pediatric cystoscope for removing the stones. This was in 97. In 98, another researcher he made a, he used a 7 French pediatric cystoscope and a 9.8 French flexible ureteroscope through an 11 French track and called this technique mini PCN. So between 95 to 2000, smaller tracks were started being used, and advancements were taking place in rod length system, chip on tip system, good cameras were coming in, even laser got introduced during these 4 5 years, and then the instruments were becoming smaller and smaller. Anyway, in China, already 11 to 22 French tracks were used for mini PCNL, but in Germany, Professor Swinlehme helped Richard Wolf to develop this mini PCNL set, which is called minimally invasive PCNL. And Dr. Udo Nagale from the same department in Germany, he helped Karl Storz to develop these instruments. And this smaller set of instruments were available, and this was called minimally invasive PCNL. In minimally invasive PCNL became so popular that in 2009, a full session during SIU in Shanghai, China was dedicated to minimally invasive PCNL. Everybody was so interested in that. Then came micro PCNL, which was being done with the help of a 4.8 French to 5 French needle, which is a very thin needle, through which this fiber optic telescope of 0.9 millimeter was passed, and laser was used to fragment the stone. But such a small hole, you cannot even do integrate stenting, you cannot remove the stones, and that were the two limitations. That was only a technique of intracorporeal lithotripsy, and therefore it did not pick up, did not become very popular. Our old friend Janak Desai, he developed Ultra Mini PCNL through 11 French track. This was his set of instruments. And another friend, Dr. Zhang Gohava, he developed Super Mini PCNL through 14 French scope. And the suction evacuation sheath, which was designed by Van Xiaopeng in 2007, This concept was used by Zengohava, and we started seeing super mini PCNL being developed by our friend Dr. Zengohava. So this continued, and miniaturization in PCNL came in a big way from 2000 to 2005 or even up to 2010. We were getting confused. Out of these techniques, which is the best techniques and which should be considered as ideal and gold standard? So these parameters were discussed. What is better and what is causing complication? So what is the renal parenchymal injury by these techniques? What is the blood loss? How much is stone clearance rates by these techniques? And when you have to make a smaller track, you have to make a stone into smaller particles, more fragmentation. So what will be the impact of that? All these parameters were studied to find out which is the best technique. When you see the renal parenchymal injury and the scar volume, this was clearly mentioned whether the track of 11 French or 30 French, there is no statistically significant difference in renal scar and volume, and nephron loss remains the same. So there is no difference between mini PCNL and a standard PCNL. Regarding blood loss, it was clearly established that if the tract size is less than 18, only 1% patients will need blood transfusion, while if the tract is 27 to 30 French, almost 6% of the patients require blood transfusion. So 6 times more blood transfusion if you increase the tract size. So it got established that the blood loss is more with the standard as compared to mini PCNL. Regarding stone clearance rates, many papers appeared in the literature comparing these two techniques, and all the papers they mentioned, the stone clearance rate remains the same whether it is a mini PCNL or a standard PCNL. Regarding fragmentation, definitely when there is a more burden of fragmentation, more smaller particles, it will take more time. Operating time will be more to remove all the fragments from inside, and then there is a formation of stone dust which may migrate to inaccessible calyces, and it may cause turbulent flow of irrigation fluid, which is an integral part of all miniaturized techniques. So there is a more chance of higher residual fragments. And if the residual fragments are inside, they may cause further stone formation, and even smallest residual fragments which we used to take as clinically insignificant stone fragments of less than 4 millimeter are actually not cannot be ignored, because almost 30% of the residual fragments are infected and continue to cause repeated infections, and in next 2 years 40% of these small segments, these small stones, will cause some problem or the other. So residual stone fragments provide increased surface area for stone growth and act as nidus for new stone formation in this lithogenic environment of a stone former patient. So the term coined insignificant residual insignificant stones is no more valid. It was also seen if you use a stone fragmenting techniques like ESWL, the stone recurrence rate is as high as 22.2% in 1 year as compared to PCNL, where you remove the whole stone intact, the stone recurrence rate was only 4.2%. So more fragmentation, more chances of residual fragments, and therefore miniaturized techniques are better because of less bleeding complications. That has been proved. But there is no difference between mini PCNL and standard PCNL as much as similar apparent stone clearance rate are concerned, and nephron loss or kidney injury remains the same. Miniaturized techniques have doubtful status because of possibility of higher recurrence rate and probably higher septic complications. So in present situation, which should be the best? It should be the middle path. PCNL track should not be too small that we cannot even remove the stones, which is the main need of the operation, and that we have to dust the stone only with laser to make the operation more expensive. And then free irrigation is not possible, thereby increasing intrapelvic pressure. So the PCNL track should not be so small, At the same time, it should not be too big, which will cause bleeding complications. And therefore, for routine PCNL, we should adopt 14 to 22 French PCNL tract size with whatever smaller nephroscope which we have. So this is the ideal approach. But at the same time, for a staghorn stone like this, we should use a 26 to 26 French nephroscope or a track of 30 French, and then remove the stone quickly and give a total stone clear. Now, what about future of PCNL? Once again, PCNL is being challenged by yet another technical advancement for management of urolithiasis, and that is by RIRS. The most lucrative factor of RIRS is that unlike PCNL, it is very easy to learn by any endoscopic surgeon, and therefore it is very appealing. But my take is, although RIRS is not a new technique and has been in use since several years, true technological advancement and enormous economical benefits to instrument manufacturing companies has come recently, and they are pressing the use of retrograde intrarenal surgery by using flexible and disposable ureterorhinoscope towards overuse and misuse, which may bring bad name to this technology in the future. And therefore, RIRS is a good technique. It is a good complementary technique, but it cannot replace the beauty of PCNL. This should be employed judiciously in appropriate cases only. They mention that PCNL causes more complication, but it is not so. The different literature studies have shown PCNL has a similar complication rate as RIRS. This meta-analysis of 17 studies involving 1717 patients showed no significant difference as regards to the complication rate. But the complications are different. With the RIRS, if you see, there are more septic complications. Not only that, there is a chance the average number of sessions for stone clearance is more than 2, hence recurrence rate is probably high. So spectrum of complications between PCNL and RIRS is different. In PCNL, there are chances of bleeding, pleural injuries, or visceral injuries, but these are short-term agonies, which can be managed easily. With RIRS, the spectrum of complications is different. If there is a sepsis, it may even lead to shock and death. If there are ureteric injuries, ureteric strictures will develop, and if there are urethral strictures, again, these are lifelong miseries. So both the techniques are good, but they should be used judiciously, and PCNL is here to stay. So PCNL is a well-established, well-documented, very economical, and most successful technique for management of upper tract urolithiasis. Several advancements and refinements have taken place in the technique over the years, so PCNL must be learned with full enthusiasm. Please do not get carried away by glamour and fashion of new techniques like the girlfriends. For permanent companionship, you need a well established and a reputed family, established background, not too demanding, not too expensive, and therefore the take home message will be PCNL is a must learn technique for all the neurosurgeons and must be mastered. Thank you very much for a patient listening. Thank you.